Yeah.
Okay, can you guys hear me?
Yes, ma'am.
Okay. I'm still waiting for a few people to get on. had to edit the Zoom link, so some of your classmates may be having trouble. If they'll go back and try it again, I think it'll let them in now. Still waiting on people. While we're waiting, how many of you actually got your textbook and read both chapters? Okay, that's a little more encouraging. So having done that, tonight we're going to start to think about how to think about this stuff. Okay, I'm still waiting on people.
Hey, Dr. Willer, when do me and Aaron meet you tomorrow? What time is that again?
Say that again.
When are we supposed to meet you tomorrow for the Head Start?
Head Start will meet at St. Augustine at 11:30.
Okay.
And Lindsay, did you ever find somebody to take your place?
I think Miss Bauer said she was asking around.
Okay, all right.
Yeah, Miss Bauer said I was good, so.
Okay. Okay, I just found Sydney Sizemore on the Zoom pictures. And Sydney, I've heard you're terrorized of me, or terrified of me.
You scared me.
Well, I
scared
want
me
you to be a
last
little bit
week.
scared. You need to be scared.
It worked.
Okay.
I came prepared today.
All right. Game face on, huh? Okay, so we were missing about, I think, 5 people. Now about 4. So I'll wait just a few more minutes.
Hey, Dr. Wheeler, I think some people thought it was at 6:15 and not 6.
It is at 6:15.
Oh, really?
Yeah, that's how it is on the schedule.
I'm tripping. Never mind.
Yeah, you are tripping a bit.
Okay, kid, calm down.
Okay, you calm down. All right. Let's see. Okay, we've got 63. So let's get started. Who can I ask first? Dipolilo. How do we refer to a patient who cannot hear very well?
A patient with a hearing disability.
Yes, or a patient with a hearing loss, or you could even say a patient with a different ability. Okay, these are all considered acceptable terms. Okay. All right. So, what are your questions for me about chapter 36? I thought it was pretty straightforward, but tell me if you have problems with any of it.
So only the legal guardian is allowed to make the decisions, not the caregiver, right?
Yes, the person who makes the legal decisions that will have legal consequences is the legal guardian. The caregiver, like with Olivia's patient today. Olivia knew, where are you? But anyway, there was a younger woman with her patient, and I think she was a caregiver, but not a legal guardian. She was there just to assist, but had we needed legal information or needed someone to make a legal determination, that would have had to been reassigned to the legal guardian, not just the caregiver.
Hey, Dr. Wheeler.
Yes.
Okay, so the patient that you're talking about with Olivia, I had her this summer, and her sister came with her. Would that if she's not really her legal guardian, but her sister's there, is that someone who could make those decisions?
If she has a piece of paper saying she can,
Okay.
but she has to be considered by law a legal guardian.
Okay.
So she has to have been given permission by a court or by the person or by a psychiatrist as who is going to make those determinations. Okay?
Dr. Wheeler,
Yes.
can you hear me?
Yes.
Can you hear me?
I don't know where you are.
So,
I can hear you.
what if they don't have a consent form? Like, we just can't say anything. Like, what if they don't bring it to the appointment?
We have to get consent somehow. Now, technically, we could temporarily get verbal consent or have someone fax something to us, but we would need that before we could proceed. Okay. Any other questions about that? All right. If you are going to use what we used to call a restraint, but it's no longer called a restraint because it's called a restriction device. And this is so the patient doesn't hurt you or themselves or someone else. What do you have to have every time before you use that device?
Consent?
consent. If you don't, by law, it is battery. And you'll learn in ethics a little bit later that battery is touching a person without their permission. So you are committing assault and battery. You're putting your hands on someone without the consent to do so. So don't do that. Juniors, what are some things that you think might change your decision about what type of anesthetic you use or how much?
Depending on what medication they're on.
Yes. Do you remember what some of those drugs were? Okay, tricyclic antidepressants is a relative contraindication. We want to try to limit the use of lidocaine to 2 carpules of 2% lidocaine with 1 to 100,000 epi. Also, some other drugs we might think about is with TCAs, you never use carbocaine. With the vasoconstrictor, levodopa, which is neocorbatrin. So if it's the carbocaine with a vasoconstrictor and they're on TCAs, you use cardiac dose or no more than 2 carbs. But it's best to stay with lidocaine and just use 2 carbs. Tarnell, you asked me today, you had some questions about the renin-angiotensin mechanism. I did put into the special needs, it's at the very bottom under the recorded lectures, it says renin-angiotensin. And it's a chart from the pharmacology book that shows you how that system works. And if you're lucky, you might be able to find a senior to tell you how that mechanism is specifically influenced. The other thing, I think you asked me about simple analytics and para-analytics or something, but I wasn't saying that. I was saying, I was comparing the two symptoms, the sympathetic nervous system versus the parasympathetic nerve system. Okay? One pumps us up for fight or flight, and that's the sympathetic. And the parasympathetic is the rest and digest or feed and breed system. Okay? So if you haven't looked at that in a while, you need to go back and revisit that. Hopefully, seniors, you've got it. All right. I had someone ask me over the weekend what telemetry, or maybe it was last week, what telemetry is and whether it is a contraindication to treating a patient in the dental office. Well, telemetry can consist of ECGs, heart monitors, pulse oximeters, respiratory monitors, and dialysis. So when patients are in any of these situations, you're probably not going to be treating them in your operatory, right? Right. Okay. And the other thing about patients, special patients, or patients with special needs, is there is the option, if you do have an anesthetic and it's someone who doesn't have control over their mouth, you can inject them after you're through with phentamylene mesylate. And the trade name for that is Oraverse. And what that drug does is reverse the effects of your local anesthetic. So it makes the patient's mouth wake up faster. So they're less likely to damage themselves. Okay, and I can write that out and put it in an email, but you do need to know that's an option. Not every office is going to have that. That's going to be an office, like a pediatric office or an office inside a hospital. Okay? All right. what can you tell me about patients with cardiovascular issues? Specifically, what is an atheroma?
It's what's the word? Not
Plaque
calculus.
in the heart. Plaque in the
Okay,
heart.
Aaron. Oh my God.
Plaque in the blood
Blood vessels.
Okay. Now, if you do have these, you have the condition of atherosclerosis. So, Jasmine, you probably sensed that I got a little irritated with today because the definition was right there in the middle of the book, and it's also in the glossary. So, an atheroma is a plaque. It's referring to the plaque itself. But if a patient has those throughout the body, we're going to call it atherosclerosis. Okay? All right. What other questions did we have? Someone asked me about non-infective endocarditis. Now, if the patient has, it's not related to bacteria, but they have an underlying immune dysfunction or something unusual in their system where they have a tendency to throw clots and be on a medication to thin their blood. And this is how they treat it. They adjust their INR by giving them some Coumadin or some other blood thinner. And if they already have the tendency to have non-bacterial infective endocarditis, do you want to take the chance of throwing some of the bacteria that we know are present in gingivitis and periodontitis into the bloodstream? What say you?
No.
No. So you're going to consult with the physician, but they're probably going to tell you, yes, you need to pre-med this patient because they are considered immunocompromised. They are not going to heal up like all the rest of us are. They have all these immune modulators that are being released without the presence of bacteria, so we may need to protect them from having bacteria lodge in those areas of the heart. Okay? But to be sure, you can always consult with the physician. And that's what we call Libman-Sachs disease. Libman Sachs. Sacks. Okay, so that should have cleared up that question. Let me think what else someone asked me. I'm afraid I can't think of the last question. Does anybody want to remind me? For those of you that read chapter 37, what did you not understand about it? And remember, when you read, you're supposed to write down things to tell me.
So when it's talking about ventricular tachycardia versus ventricular fibrillation, would the tachycardia just be like the increased speed, and then the fibrillation would just be abnormal beats?
Yes,
Okay.
the ventricular tachycardia is going faster, but it's contracting. In the defibrillation state, or fibrillation, I can't remember how they say it, but it is quivering. It's not quite even contracting.
Okay.
Okay?
Thank you.
All right. Peyton, you were going to ask me something tonight.
Yeah, it was, it might be confusing though.
Oh,
'cause
no. I remember
was-
now what it was.
It was on one of the modules.
Yes. Okay, so this was about how you can tactfully ask a patient if they're using an illegal substance or a controlled substance? Well, you just ask them matter of factly, do you use any uncontrolled or controlled substances or any recreational drugs? And before you inject, you ask them again. Now, just to be sure, I want to be sure, so I don't do anything to hurt you, you haven't used anything recreational. Okay? But if they act like they are tweaking, and nowadays we're taking temperature and their temperature is elevated, do not treat them. You'll get into a medical problem, okay? Because if they are moving around like they are tweaking, and I hope everybody knows what I mean, and their temperature is elevated, you're going to reappoint them, okay? I can't tell you,
Sorry.
I can't tell you how many times I have a friend who is a nurse for a obstetrician, and I can't tell you how many times they have reappointed or had to treat patients who decided they needed a hit of amphetamines before they went to have their baby.
What if the patient doesn't display any like symptoms that they're on a or a controlled or just on recreational drugs, and you inject them and something were to happen? Like, are we, because you said only ask if the patient looks like they're.
No, you ask everybody.
Every time?
Yeah.
Every time ask a patient. Okay.
Yeah, until you know your patients pretty well.
Okay.
All right.
And if they lie to us and we still ask them and something were to happen, it's on them.
It's on them.
Okay.
That's part of their contract with us. They have to give us their correct information. We have to treat them accordingly.
So just to be safe, we ask every patient, are you taking?
Yeah, because there's people walk in all the time. I don't know they smoke dope, but they do.
Yeah.
I can't always smell it.
Yeah.
Or maybe they haven't smoked that day. Not yet, anyway. All right. What else did you read about that you have questions about? Come on.
So the INR testing, I get that normal is 1, but you had said that the treatment of venous thromboembolism, the INR testing needs to be 2 to 3. What exactly does that mean?
That means the blood is, so to speak, thinner or less likely to clot.
Okay.
So they raise their INR, they thin their blood out with warfarin or Coumadin so that they are less likely to form blood clots.
Okay.
And then you don't have those thromboembolic effects.
Dr. Wheeler?
Yes.
Will they know if they need to be, like what level they need to be at? Like if they need to be between a 2 and a 3 or 2.5?
Most people will, and if they don't, they're going to check with the physician.
So they'll know if they're kind of off track.
Most of them will. And you know, patients who really stay on top of their diabetes will tell us their HbA1c right offhand. You just say, oh yeah, I had it last time it was 6, so they said I was good. And juniors will talk more about that. It's a way to measure how someone is monitoring their sugar levels over a period of 2 to 3 months. All right, let me see if I need to pull out any other. All right, did we get all that? Everybody knows what the atheroma is, right? Okay, one thing that we didn't really talk about, we can also have atrial fibrillation, which is where the atria are basically quivering and not functioning well. We can have bradycardia, which is a slow heart rate, or tachycardia, which is a high heart rate. If there's something wrong with the electrical system in the heart, the patient may have an arrhythmia. They can also have what we call PVCs, pre-ventricular contractions. And your book talks about this. on 597. And some people may have them ever so often normally, but if it becomes more common, they may need to be treated with it.
Is it okay if we backtrack for just a moment?
Yes.
I understand that we need to have that. So I'm going back to the INR.
Yes.
I understand that we have to have that ratio so that their blood doesn't clot. But how exactly do you figure out that ratio to make sure that you have like the 2 to 3?
A blood test.
I don't know how to like figure that out.
Simple blood test.
Oh, okay. So you
Yeah.
just said, okay.
You measure how long it takes for their blood to clot.
Okay.
So
I didn't know if like that was like available.
Sure. You want their blood to not clot as fast or not as easily.
Okay.
So
do we have something for that like in office?
There probably are some tests to test, yes, for that in office, not in most standard dental offices.
Okay.
We'll have to call the physician to find out.
Gotcha. Okay, thank you.
Okay. All right. Yes.
With the third degree heart block, does that mean they automatically have a pacemaker, or is that like how it's treated?
It may be, because that's the most severe of the heart blocks. It talks about a first degree heart block where the patients may have not even know they have symptoms or not even be aware of it. And the second degree where they can have a skipping in beats and they may experience dizziness and faintness. But the third degree, which is a complete atrial ventricular heart block, well, they will have a problem in the electrical system. And so they will have to have some kind of help in regulating their heart. And yes, Jackie, they're probably going to have a pacemaker by the time they get to that point. Now, one thing you need to know that today, most of the pacemakers are shielded, so it doesn't hurt us, especially to use a piezo, because piezo doesn't generate interference. But some people that have a pacemaker, you may have to tell them if they have a Sonicare or an Oral-B, don't get too close to your charger. That may interfere with your pacemaker. Okay?
Was there a certain year that like shields on pacemakers became mandatory, or there's still?
I think it became more common where people started making them shielded about 10 to 15 years ago. So most people you see nowadays are going to have shielded pacemakers. All right.
So if it's shielded, do they not have to worry about the toothbrush charger?
There are some some are not properly shielded, may have a problem with the charger. But if they're shielded, you're probably fine. Okay? But they want you to stay about 6 inches between the charger and your heart battery, which should be pretty easy to do. You know, put your ultrasonic up like this, away from you. You probably can't see my arms, but don't hold it up by your heart. Put it out here, put it up. Okay. And we've already talked a little bit about atherosclerosis. And that is just having those atheromas in different areas. That's the condition. The atheroma itself is a plaque. All right. Now, a lot of these medications, I don't ask you about specifically on any tests, but how can I say this tactfully? If you don't know what a beta blocker ends in by now, then I don't know what to do for you. If you don't know what a calcium channel blocker ends in, and just to give you a heads up, juniors, beta blocker ends in OLOL, O-L-O-L. So propranolol metoprolol. Those are some beta blockers. A pine drug, or a drug that ends in PINE, is a calcium channel blocker. That's something like lisinopril, very common drug.
Can you repeat that?
Yes. Just the lisinopril or the other one?
Yeah, all of that.
Beta blocker is OLOL, OLOL. A calcium channel blocker, or PINE, like amlodipine. An ACE inhibitor is a pril drug, lisinopril. So, seniors, if I come up to you and grab your health history, just know you're getting ready to be quizzed. And if you're treating that patient, you should know something about the drugs they're taking. Okay? The other thing you should know is what today's classification is for hypertension and pre-hypertension, and stage 1, stage 2. Normal is less than 120/80. Anywhere from 120 to, and this is on page 599 in your textbook. Andy Lamb, did you get your textbook?
Yes.
Have you read it? Okay.
Skimmed. I didn't get home.
Okay. Look at page 599.
You already caused me battery today, technically.
Well, I'm your instructor. I can do that.
I was a witness.
It's part of the contract. Okay, so pre-hypertension is anywhere where your systolic is 120 to 139 over a diastolic of 80 to 89. Anything above that, you start to get into stage 1 hypertension, and that's when you have to start treating the patient. And seniors, what's that first line drug we use to treat hypertension?
Diuretic.
Yes, a diuretic. That's just a drug, juniors, that helps push fluids off the system. Because if you have less fluid circulating in the plumbing, the pressure will go down. And I hope that makes sense to you. All right. Oh, someone asked me what makes atheroscleromas worse. Well, it's the consumption of lipids or fats. So you want to get your LDL levels down and your HDL levels up. Is that right, Maddie? Jameson, right?
What'd you say? Can you repeat that?
You want to make your LDL go down and your what go up?
Your HDL go up.
Okay. All right. But periodontal infections can be very contributory to thrombolytic or clotting problems, okay, because of the bacteria involved. So if the patient's mouth is healthier, the heart will be healthier. Does that make sense? All right, let me see if anything else I need to tell you.
I was gonna ask, the updated like blood pressure classifications that we learned in like Theory 1 and Perio and stuff like that, they're different than the ones that they have on 599. So we're supposed to know the book ones for your class?
Yeah, I think so. Let me look over at my official chart here. Let's see. Yep, that's the same. That should be. It looks like stage 2 is a little bit lower on, yeah, my official recommendations that I had last printed from UMS was stage 1 is 130 to 139, and the diastolic is 80 to 89, and then above that is stage 2. But it doesn't hurt to be cautious in either one of these levels. You know, we used to think, oh, okay, 150 over 90, that's probably okay. Well, now we know we may need to intervene a little bit sooner. Okay. Mine started going up when I started teaching hygiene, and then I had to get on medication. And it's not all due to hygiene. It's because of my age, too.
Dr. Wheeler, is our cutoff 160 for blood pressure?
In general. Now, either Dr. Zeller and I will make that call depending on what we see. If you see a patient that is on 3 or 4 different hypertensive drugs, like maybe they're on a lisinopril, they're on losartan, they're on a diuretic, that may be as good as it gets for them. Some patients, I remember Miss Dorothy, who you guys don't remember, but she used to work in the clinic. She was always at about 200 over 100, and Dr. Howe, who is over in the OHC, had to get a letter for her from her physician saying, that's as good as it gets, go ahead and treat her. Maddie, what? What are you smirking about? Nothing? Okay.
Just having a good day, Dr. Wheeler.
What?
I'm just having a good day.
Did you come to clinic today?
I was off today.
Yeah, that's why you're having a good day. Okay. If someone is terrified of coming to the dental office, especially if they've never been, what are some techniques that you can use to help them adjust?
You can make them comfortable, and then after they're more relaxed, you can retake it.
Okay, but what if I'm just talking about off the street, they don't have any hypertension problems, but maybe they're a patient with different abilities, and they're not comfortable with coming into a bright dental office with all this sound going on in the background.
You just have an acclimation appointment first.
Okay, yes, you have a acclimation appointment or a desensitization appointment where you let the patient come in. I used to have little kids. They'd come in, they'd never been to the dentist before, they'd come in, they'd sit in a chair, we'd lift them up, raise them down, lift them up, raise them down. We sometimes, if they were up to it, would shine the light on their mouth and put a mirror in their mouth. And sometimes that's as far as we got. It's different with every kid, okay? Some will hop into your chair and just open up and be ready to go, and others will look at you, I'm not getting anywhere near that thing. All right. All right, let me flip over to my other PowerPoint. Did you look at the ADH rules and regulations for the use of restraints, or what we now call restrictive devices? That's in with your PowerPoints. If you have not looked at that, please do. But every time you use it, you need a consent form. So if I had to ask you, what other factors besides cardiovascular disease and periodontal? What other factors figure into that? Cardiovascular disease and periodontal disease. Age have anything to do with it? Diet, okay. Age have anything to do with it? Yes, I said as I aged, I had to get on blood pressure medication. Gender, does that have anything to do with it? Yes.
Stress.
What?
Stress.
Stress, yes. What else?
Smoking.
Okay, smoking. And what else?
Genetics.
What if I have a family history of it? Yeah, that's related. You can have hereditary as an effect. Okay, does everybody understand exactly how the heart works? Again, if you say nothing, I assume you do. If we have right-sided heart failure, where are we going to see it evident? Kelty.
The feet, they're gonna swell.
Okay, you're not Kelty, but okay. All right, yes, you're going to see pitting edema in the ankles, and I'm sure, Jackie, that Kelty is totally fine with that. If they have left-sided heart failure, where are we going to see it?
Breathing problems.
Yes, breathing problems, congestion in the lungs. That should make sense to you, does it? If not, you need to study that diagram of the heart.
Hey, Dr. Wheeler.
Yep.
I might just have it wrote down wrong from our lecture, but I have that left-sided is from like the pitted edema.
I have that too.
I have that written from the lecture as well.
Okay, maybe I said it backwards.
Yeah. Okay, I just want to double check that I didn't have it written down
Yeah,
wrong.
because left-sided is the oxygenated.
It's on page 603.
Yeah, it is. It's in your book. Yeah, I probably said it backwards. But remember, the problems are going to be left-sided, they're going to have difficulty breathing, and right-sided, it's going to be in the edema. Is that correct? No?
I have it down that left-sided heart failure is pitting in the ankles or pitting like and the right side is difficulty breathing.
Are you looking on page 603?
The book has left is lungs, right is ankles.
Right.
Okay, I'll put notes off of the lecture. I might have.
I think the lecture has it backwards.
Maybe I said it backwards on the lecture. Sorry about that.
It's okay.
But left, according to your book, left is difficulty breathing, and right side is pitting edema in the ankles. Okay, we know that infections in the body can go anywhere. So anyone that is immunocompromised in any way, you need to pre-med. That may require a consult with the physician. You need to be vaguely familiar
Dr.
with...
Wheeler?
Yes.
Before we go on, can you define immunocompromised? Like, I view my mom as immunocompromised and she has MS, but I don't think that, so she would need to be pre-medicated before a demo?
She might need to consult with her physician, but that's more of a, not so much an immunocompromise as a physical problem, as a physical impairment. But she could very well be immunocompromised, especially if she's older. Is she on multiple medications?
Yeah.
Okay. So she might be a little more at risk for getting sick.
Okay.
Okay. But immunocompromised is someone that is weaker in their defense systems. They can't protect themselves as well as a normal, functioning, healthy human being. Okay. All right. What other questions do you have?
Could you explain the first, second, and third degree heart block more?
Yes. Okay, so it's a matter of degrees. One, heart block one, the patient may not even know they have it. They may be unaware of it. They may have some kind of coronary blockage, but they're not aware of it. Or if they're on beta blockers, they can develop a first degree heart block. But their symptoms may be non-existent. They would only find this on an ECG or with a some kind of cardiac exam. Second degree heart block is occasional skipping and sometimes dizziness. So sometimes things are not quite getting oxygenated as well as they should. And by heart block, I mean that it's a type of arrhythmia where they have a malfunction of the electrical system that controls our heart. Do you remember the SA node and all that from basic anatomy? Okay, if something goes wonky in that area, then they could have some problems with how their heart functions. If it's a third degree heart block, that's much more severe, and they're probably going to be on a pacemaker just to keep them regular.
Thank you.
Okay.
So are the degrees progressive, or are they just separate classifications?
They are separate classifications, but they could become progressive. Could you go from a first degree to a third degree? Sure. If you have some conditions that cause you to debilitate. All right. And if you notice, a lot of the drugs that are used for anti-arrhythmia have oral side effects. I don't know what you're laughing about, Lindley, but okay. Like salivation, weird taste, hyperplasia, xerostomia, and a sensitive gag reflex. So look at that chart in your book.
That's with hypertensive medications, right? Is that what we're talking about?
What? Yes.
Okay.
Yes. That would have been covered under our cardiovascular chapter in Pharm.
Dr. Wheeler?
Yep.
So, my only concern is just our lack of knowledge of some of the medications, just because we haven't gone through Pharm or anything like that. What's some things that we could go over maybe that could just give us a basic knowledge of things? Because some of the things that you said earlier, I have not even heard of at all.
All right. You are supposed to have access to my pharmacology, I believe. Claire was going to open that up for you.
We definitely don't.
We're aware of.
Yeah, no.
Okay. I'll double check that with her because there are some things I want you to review. The other thing I want you to do is go over the parasympathetic and the sympathetic nervous systems and how those work. Because if you know that pretty well, you can predict what's going to happen with most cardiac conditions and what drug they will need. Okay, what other questions, juniors or seniors?
Okay, so I have a question. I wrote this down and I put a question mark by it while I was watching the lecture. And you said if you need oral sedation, don't use a sedative. They might become agitated or alert, talking about the patient.
Oh, it's talking about a paradoxical reaction. I think I know what you're talking about, MA. Some patients are not always going to react the way you expect to a medication. Sometimes they have just the opposite effect. And I found this out myself when I had a young kid who was about 10, a daughter of a friend, and I was trying to treat her, and I thought, well, I'll give her some Valium. I thought that'll just sedate her and she will be fine. Well, it had her bouncing off the walls. So it had a paradoxical or opposite effect. And again, just to enunciate better, that's paradoxical. So they will not have the expected effect. Some patients will have just the opposite. It's just the way their body works.
So would you use like other techniques, or how would you do that to prevent that reaction?
What would we use on a kid to sedate them? Since you brought it up.
Chloral hydrate.
All right, chloral hydrate. Okay. What else? What's great for kids?
Nitrous.
Nitrous oxide. Okay.
Is this in a book that's saying like what's good for kids, or are we just supposed to know
Nope.
this?
We're learning as we go.
Okay.
And yes, this is a disadvantage, but this is what I was told we were going to do.
For if they're going to have an opposite effect to a medication, is that just trial and error or allergies, or how would we even know that?
It may be, you kind of learn as you go along that there are some drugs that will have a paradoxical effect on a certain age group. Like I was talking about Valium with kids. That does not cause sedation. Any other questions?
What is the difference between supraventricular tachycardia and ventricular tachycardia?
Okay, so supra is where?
Above.
Okay, so it says ventrotachycardia, or what they refer to as VT, is a problem in the ventricle area. But a supraventricle would be in a certain area, right? Now, where would that be? What's supra mean?
Above.
Above. More to the top of the ventricle. So we've got that electrical node system, and it runs all the way through the heart, right? So depending on where it's failing is whether you're going to have ventricular or supraventricular. If it's higher up, then supra, and if it's ventricle, it'll be more in the center. Okay.
So right after chloral hydrate, back to the question with kids, right after chloral hydrate, what popped in my head was Versed. What do we use Versed for again?
We use that for that's like under sedation. I mean, or not under sedation, but that's putting a kid slightly out. And we use that on children because it's very short acting. It doesn't last long.
So that would be like a step above nitrous, like when we really needed to knock it out.
Yes.
Okay.
And sometimes you combine those drugs to achieve what? What do we call that?
Balanced anesthesia.
Balanced anesthesia. Okay. Okay, so what other questions do we have? I can't tell what you don't know if you can't tell me. Ashley named. You look like you want to say something.
I'm kind of lost on most of it, so.
You have your textbook?
Yes, ma'am.
Okay, where are you lost?
It's like I guess just memorizing the medications. I think like you said, we're at kind of a disadvantage But we'll get through it. It's fine.
What I want you to learn now, excuse me, is mostly the condition and what it might be treated for. Because this is one of the things when your patient comes in and they're on a beta blocker. Well, you want to know why specifically are they taking that beta blocker? Are they taking it because they have a heart block? Are they taking it because they have atrial fibrillation? Are they taking it because they have, oh, I don't know, migraines? Or you want to know why they're taking that particular drug. Okay, some people may be taking a beta blocker for anxiety, such as a dental hygiene student. We have had dental hygiene students that have been on beta blockers just for that very reason, to lower their anxiety, because when they get excited or anxious, their heart rate goes up. Okay, this slows them down a little bit, chills them out. Okay, what other questions do you have? Julie, I know you want to say something. Julie Jones.
I really think I'm okay right now.
All right. Juniors, who else is feeling lost? Well, let me tell you what I do. I stay late most nights, and I always tell people you can call me if you need me, just don't ask me something stupid, which I had some senior students ask me today or this weekend, which things I think you should have known and we should have learned last semester. I'm going to get a little aggravated with that. But if you are a junior, you really have a right to not know this stuff. But you're going to have to figure it out somehow, because we're going to have to get through this. But mainly, right now, if there's a drug on a test question, I'm going to tell you about it. I want you to learn the conditions, the possibilities. Let me see what other faces I see here.
Dr. Wheeler, I actually do have a question.
Okay.
So when the book was talking about valvular heart disease, like the aortic stenosis and the aortic regurgitation,
yes,
I don't think I'm actually understanding what the difference is.
Okay. Well, regurgitation is you're getting that valve is not closing all the way off. It's just, can you see my hands? The valve is just, it's almost closing off, but not quite. It's leaking a little bit. Stenosis, what would that be? Let me think of a good way to explain that.
So with stenosis, do you have regurgitation, or is regurgitation just?
Well, think of regurgitation as a leaky valve.
Yeah. It says incomplete opening of the valve, so.
Does that mean that the flow isn't complete with stenosis?
Stenosis, yes, it's restricted. Okay, maybe it's open a little bit, but it never opens up fully. Okay, I think I'm back on track now. Regurgitation, it doesn't quite close all the way. Stenosis, it doesn't quite open up fully, so you don't get the full measure of what's being transported. Does that make more sense?
So, but I guess I'm confused. I mean, maybe I'm thinking too much about it, but I guess I'm confused because either way, it's not open all the way. So
well,
how do we have two different names for it?
Okay, let me talk about it this way. Let me get my picture back on so I can see if I'm doing my hands right. Okay, so in stenosis, it never opens up fully. It just lets a little bit out. In regurgitation, it opens, but it never closes down. Does that make more sense?
Maybe a little, yeah.
Okay, so in regurgitation, it opens up, but it doesn't close fully. In stenosis, it doesn't open up. It just opens a little bit.
So they both would have backflow?
You are going to have a backflow, but you're not going to have that forward flow. So you're going to, in regurgitation, you're going to let some out, but you're going to stop it, close partial way down and leak. But you're not going to have complete closure except for right at the beginning of stenosis. And then it opens up, or no, it doesn't. I'm sorry, I'm saying this backwards. Okay, regurgitation, it opens up, but it never closes all the way down. Stenosis, it never opens up fully. It just lets a little bit out. So it has much the same effect. Does that make more sense?
So either way, you have intermingling.
Yes. Either way, you have commingling of the oxygenated blood and the non-oxygenated blood.
Okay, I just wanted to make sure I wasn't missing like a distinct difference between the two.
I don't think so. I'll do some more research, but I don't think so. Okay. All right. What else?
Is that caused congenitally?
Could be. If you're born with a bad valve. What happens to a lot of people that have a heart disease and one of the valves goes bad? If they have a pig valve that replaces that valve, do they need pre-medications?
No.
No, because it's not artificial. It's a pig valve. Okay. If it is a man-made or artificial valve, does it have to be pre-medicated? Yes. And a heart valve is always. I will also put that cardiac conditions for which we need pre-med into with your PowerPoints or with your at the end of the renin-angiotensin section. Okay. So what I fear that is not happening is you're not actually sitting down and reading the book and absorbing the information. I fear that you are skimming it. And the reason I fear that is because of some of the questions I get. Right? You've got to sit down and read this stuff. You've got to understand it or try to understand it. You can't skim it. You can't go through and say, okay, yeah, I know that. Okay, now you have to sit down and read it.
This may be a dumb question, but is a pig valve in the book?
No, it's not in this book, but I'm telling you, it will be in pharmacology. But if someone has a pig valve, that's a natural substance. That's not artificial or man-made. So we don't have to pre-medicate that.
Dr. Wheeler?
Yes.
Okay, I just want to make things a little clear. So we just need to focus on hypertension, angina, pectoris, not so much the medications. I think the juniors are getting kind of freaked out because I think that they're focusing they feel like they just need to know all the medications. But what you're trying to say is you just want us to know hypertension and yes, and not so much as the medication part.
Yes.
Okay,
I'm pretty sure there are no questions in the test. Let me just go back and look.
So we don't need to focus on medications, but do you want us to focus on to treat heart failure, beta blockers as a whole, ACE inhibitors, and not so much the actual drug?
Yeah.
Okay.
I think
they're just kind of just getting freaked out. about it.
I'm sure they are. Since some of them are terrified of me.
Dr. Wheeler,
Yeah.
do you ever do study guides? I'm just wondering for.
Yes, it's called a lecture. Do you know how to outline a chapter?
Yes, ma'am. You actually asked that in the interview. Is that is that pretty much a study guide?
Yep.
All of it?
If you want to know how to do a proper study guide, talk to this man up here in the corner, Jason Harper. I believe
a lot of us, sorry, Dr. Wheeler, but a lot of us make Quizlets too. So
okay, Quizlets, yeah.
Just try to in past seniors, just try to look our names up and we'll try to share them with y'all.
That's a good idea. I forgot about Quizlets.
Dr. Wheeler.
Yeah.
So on the assignments, I know we're supposed to, I guess, email them, but I think you were talking to Madeline earlier about maybe finding a way to, to turn them in. That way we don't
have to. Well, I think Miss Warren told me that if I would go to dentalcare.com, it would show me a list of who's done them and who hasn't.
Okay.
And I've been getting, for everything that you send me, I get something separate for dentalcare.com saying one of your students has completed this assignment.
Yeah. So I remember, we don't want your email to fill up and then.
Yeah. So don't send me that. Just do the assignment and dentalcare.com will send me the notification.
I think as long as after you finish the assignment, it made you go through 3 different finishing step processes, and on the 3rd one, it makes you scroll down and enter in your assignment number,
yes.
And then it automatically send it to you.
Yes, that is correct. Now I just have to figure out where to look on dentalcare.com as to find that list. All right. What else is everybody freaked out about, Maddie? Since you're the only one that wants to talk.
I do have a question. This might have been answered. So you want to? It might have been answered because I kind of.
You need some milk.
No, but so that one assignment is due because our
day.
Can we do all the assignments at our own time or? Yeah,
Maddie, those are open until May 1st. The only one you need to make sure you get done before the end of January is 5:45. I see Mary Addison and Madeline and Julie laughing, but I don't know if the rest of you know what that means. But they showed me the video today of this woman just randomly yelling at this guy who's having problems, saying he needs some milk. And Madeline was laughing so hard, I didn't quite get it, but she said she would pay me if I said that tonight, or something to that effect.
No monies will be exchanged.
Okay, no monies will be exchanged.
I said I'd laugh. Okay.
Yeah, that's true. Okay, it's pretty dull talking to a computer, so every once in a while we got to kind of shake things up. You will hear all kinds of things in my lectures, especially if you go into the pharmacology lectures. Sometimes I talk in a British accent, and sometimes I talk like a radio announcer or a news announcer. But anyway, it's just to keep things lively because I get tired of talking to the computer, even though I can see your faces. All right. Anything else, juniors or seniors? Okay, Rachel shaking her head no. Thompson saying no. Sierra saying no. Kirsten saying no. Brianna Rogers saying no. Bree Phillips is scratching her nose. What do you say?
I say I'm good.
Okay, all right. Okay.
Dr. Wheeler?
Yes.
St. Augustine's Church, is that in North Little Rock, right?
Yes. I have the address right here on my phone.
Okay, I think I found it. I was just making sure it was in North Little Rock.
let me look at my phone. For the juniors, we have to go do some screenings at Head Start. And St. Augustine is 1410 East 2nd Street, North Little Rock. So some of you will be going, some of you juniors will be going on these, I think, in February. But tomorrow we're going to start at St. Augustine and then go to Metropolitan Tech, I think it was. May have to look back at my email. All right, any more questions? What, Carly?
Nothing. I'm just tired.
Done for the day, right?
I'm capped out.
Okay. Oh, me too. All right. Well, I think the She Needs Milk is probably the highlight of the lecture for me, Madeline, and Emma, and Julia, maybe.
I have seen it. My brother showed me it, and I was confused, but it is.
I think it is very confusing, but some of your classmates think it's extremely funny, so.
I have finally lived, Dr. Wheeler. I have finally lived after hearing you say that.
Okay, all right.
It's only funny because you said it.
Why?
Like it sounded 10 times funnier when you just said it than it did in the video.
Why?
It just did.
Oh, it's probably my RBF. Okay, all right. Okay, is everybody good for tonight? Next week is chapter 38, and that is respiratory. Juniors, this will be a little hard for you as well. But again, if you'll just try to understand the disease, don't worry too much about the medications. It is actually a shorter chapter, gives you a little bit of a break. It's about, looks like about 9 pages. And some of this, I think, if we just try to grasp what's happening to the body and don't worry so much about the medications. If there's any specific questions about the medications, I'll go back and look at my tests and give you a heads up, okay? All right. Anything else?
Wait, I hate to butt in. So but on the test, you said if there's anything about the medications, you would let us know what it is.
Yes, ma'am. Okay. And you are not butting in if you're asking an honest question. That's what you need to do. You need to be your own advocate. What, Kelty?
My husband made me dinner and I'm just waiting to eat
Oh, sorry. Okay. All right. There are no more questions. We're going to get off, okay? You have my number. You can shoot me a text. Just make sure it's a reasonable question. All right. Good night.